think you go to view and slideshow.
Thanks. Okay, hi, Dr. Pohl. This is our presentation.
Okay, so the first thing being discussed is our team definition of radical belonging using literature review. And we discussed several main points in our definition. So recognizing the roles and responsibilities of everyone's professional role in the workplace, respecting and listening to everyone's opinions and making everyone feel they are being heard and valued, communication among interprofessional team members and acceptance and understanding of differing opinions, ensuring a safe working environment where everyone feels comfortable performing their job and expressing concerns, and finally, acknowledging everyone's contribution to the workplace and celebrating the diversity of both cultural background and professional roles.
So why is belonging in healthcare teams important? We came up with a sense of belonging in the workplace will improve well-being of individuals, improve team well-being and collaboration, improve retention of healthcare teams in the workplace, and improve feelings of safety to share beliefs and concerns with others.
So we have a comprehensive proposal.
Okay, so for our comprehensive proposal, it consists of organizational, team, and individual level recommendations. So for the first one, we want to make sure that translator services are readily accessible. Even though these are already active in the hospitals, they are shown by research to not actually be readily accessible and available. So in a study by the Journal of General Internal Medicine, they did a qualitative study using in-depth interviews on why research shows that physicians underuse the interpretation services in hospitals, and concluded that 4 major themes contributed and then emerged. One being that physicians were very aware of their underuse of the interpretation services and called this, quote, just getting by. 2, a decision whether or not to use interpretation services was made in regards to clinical decision-making, whether in-depth communication was necessary or not based on their own constraints of time. 3, family members or physicians could use their own language skills, which could increase the amount of time needed to get a hold of an interpreter. And 4, physicians admitted to normalizing the underuse of translator services, even though they were aware these patients were receiving diminished quality of care. So kind of because of this, we also want to improve data collection from members of marginalized communities, because in other marginalized communities, such as individuals Hispanic, Black, or African American descent, LGBTQ communities, and individuals with obesity, can lead to inaccurate data solely because this population of people is often stigmatized in care and therefore just doesn't seek care. So with a lower population of people being studied, data can be skewed. And so we should fix the problem at the root by including organization-wide diversity training, providing opportunities for patients to give quality feedback, and furthermore, allowing sick days, because when workers are burnt out, they're less likely to recognize when problems are occurring. And additionally, they will likely not take the time to go above and beyond for their patients. Next slide. So from the team level recommendations, we want to encourage inclusive and supportive language during team interactions, specifically during the pandemic, and hold the team accountable for inappropriate, demeaning, and racist comments. We want to host regular weekly team huddles to support open communication amongst all of the interprofessional teams so that each profession is heard. The lack of time and staffing can lead to often mistakes and miscommunications. And so we want to make sure that all of these things are done and upheld both within individual members of the team, but also including conversations via phone and hallway conversations so that people of other marginalized communities will actually seek care, and therefore we can prevent illnesses that they might face rather than treat them. Next slide. From an individual level perspective, we want to make sure that we're providing opportunities for individuals to submit feedback to the organization on how to further improve inclusivity in the workplace setting. We also want to host training seminars for individuals to reflect on their own biases and have an adequate and beneficial reporting system for employees who have gone against policy. This is important because in order to have a fine balance between, we need to have a fine balance between discipline when it comes to like demeaning and racist comments that are being made, but also have an open communication so that we can recognize our internal biases and therefore be able to fix them amongst each other.
Okay, so how are interventions going to impact our facilities and patients in regards to COVID-19? The organization implements should help increase communication between patients who cannot speak a language that is being provided to them by a provider, which should hopefully help outcomes. And team-wise, having an identified chain of command will allow patients to, or patients presenting with COVID to have proper protocol and care followed efficiently. The huddle meetings hopefully will prevent burnout or overworking of team members and give the chance to address any biases related to COVID. And individually, hopefully the feedback from the surveys will allow us to be aware of any issues that we are facing related to COVID-19.
Yeah, so I'm going to talk about what are the interventional steps we can take to address these challenges, and they split up in short term and long term. In the short term, I think, before we can fix the problem, we have to invest time and energy to really understand the problem. I think it's important to do it really systematically. So I would want to do is like hire a quality improvement team. Like their job is to dedicate themselves to like find the problems. That should involve like talking to people on the ground level, like what are the actual problems? Because I think it would be interesting and intellectually stimulating for the QI team to kind of like pontificate, oh, what do we think are the problems? But I think it would be a lot more helpful to like hear from our actual healthcare team. I think it'd be important to develop a systematic strategy to ensure all voices are heard. There's plenty of healthcare work, different types of workers on our team. So we want to make sure everyone is represented. The last thing about this is we should probably develop a standardized tool, probably similar to the ones we use in class, where we have a Likert 1 to 5 scale, and we just click some like what they think about the company, and like they can give some feedback about what they think could be fixed. And the other part is like, it's important for this QI team to really invest in the rest of the healthcare team. I think when you're a worker, you can tell what's like just another task to do, or when like you feel like you're really cared about. So it's important to respect the team's time and effort. There should be protected time to like do these QI surveys. Hopefully it won't be just like an email where they have to answer like a bunch of questions. No one's going to put their whole heart into that. So maybe like we could potentially protect time during the workday to accomplish these tasks. The other thing is incentivize the team to buy into the mission. I was just brainstorming, and I thought something that might be good is like maybe dangle a potential like leadership role or opportunity for the healthcare team, so people will be really invested in. I know like as a med student, something they do is like they label like you as like a leader of some sort if you like lead feedback for something. So that might be a potential idea. In terms of the long-term interventional steps, once the QI team goes out, does surveys, and actually figures out what the problems are, like we need to design interventions tailored to the needs of the healthcare team. The QI team should design interventions based on the problems identified, and they should present the ideas for the interventions to members of the team to get feedback prior to implementation. Like, if I feel like once you're on the ground floor, you have a good idea if something will work or not. So we could make further improvements before we implement it. And then once we implement them, we also need to develop methods to assess the effectiveness of their interventions. Once again, we need to develop standardized tools for our employees to provide feedback. We need to protect time to complete the standardized tools. That way the feedback will be meaningful as opposed to just something to do. And then the QI team should meet and discuss feedback and implement these suggestions. And, I thought a good idea would be to have representatives at these meetings from different sectors of the system to provide feedback.
All right, so for metrics of success, it's long been known that different populations have different health outcomes, and that was further shown during COVID times, where Black and other ethnic minorities had higher rates of severe illness and mortality. So one way that we are thinking about assessing the metrics of success is that we can record the rates of mortality among different groups of patients before and after our intervention, and look at the difference in mortality between these groups over time. And because we expect our intervention to be inclusive of different perspectives and experiences and promote teamwork, we expect patient care to improve, which would be reflected on patient satisfaction surveys. That will also be reflected in the overall morale and well-being of the care team, which we can assess with anonymous evaluations by team members. And since our intervention also includes training sessions for team members to reflect on their own biases, we can check how successful that will be by tracking attendance at these training sessions and seeing the results of pre and post surveys, assessing attendees' other understanding of their cognitive biases. And finally, we can look at the amount and content of the feedback that's been submitted by individuals about how to improve inclusion and reports about employees who have gone against our policy.
So to move on to sustainability and scalability in other healthcare settings and organizations. So first we're going to talk about sustainability. Kind of to put this in context, when we think about sustainability, we think about it as there's multiple definitions, but one that I liked was the ability to maintain a change once it has been implemented. When I did a literature review of kind of what it means for a change to be sustainable, I found a 2018 literature review of sustainability approaches, which identified important constructs to a sustainable intervention. Each sustainability measure identified related to one or more of the constructs. So kind of just to go through these kind of relate to some of the points that we just talked about. So first, reassess the use of in-person translators every 2 to 3 years using a survey to determine the days, times of the week when translators are most needed and times when they're in the highest demand. So that way we can ensure that we're making sustainable use of our resources. We can also evaluate the effectiveness of the diversity training we've talked about with the post-training surveys that Amy just mentioned. And the number of reports filed related to issues of diversity, equity, and inclusion, such as bias. So this kind of is a way of assessing the stakeholders, which are the people kind of involved that are affected by this change, how much they're participating, and also shows that it's effective. And then we can also reevaluate the interval between the diversity training sessions every 5 years, and perhaps hold diversity training approximately the same interval as turnover rate. That way we're kind of holding it frequently enough where everyone will be able to participate, but not so often that it might become repetitive for some people. And then on a quarterly basis, we can survey team members and team leaders to determine if the team huddles continue to be beneficial. That way we can only continue to implement them if everyone thinks they're helpful and not just something else to do. So now to talk about scalability. So again, the definition is deliberate efforts to increase the impact of the successfully tested health innovation so as to benefit more people and to foster policy and program development on a lasting basis. And that definition comes from the WHO. And then similar to the last slide, I found a 2019 article in the Health Policy and Planning Journal that identified 5 critical factors when planning to scale up. So again, each scalability point listed relates to one of our changes we want to implement in one of the critical factors identified in the article. So first, we have to define the goal of scalability. So one goal that we can have would be to implement our idea beyond just flu hospital to include all hospitals in the SSM system. In a way we could do this would be to include hospitals that are closest first, and then progress to ones that are furthest away. So that can be our scale up strategy. And then prior to moving to the scale up phase of our improvement, we should make sure that our ideas are effective and sustainable for a period of time. I put 3 years, but that's not really, that was just a number I picked. So we want to make sure our ideas work before we scale up. And then additionally, we can also hire translators to work at multiple institutions and perhaps travel between them on a single day. So this would allow for cost sharing and between the institutions and providing a wider variety of language services, perhaps. So this relates to attributes of the innovation. So just being able to cost share. And then lastly, we can also enable and offer incentives to staff willing to cross-train and work at multiple locations, perhaps just like a slight increase in pay or something like that. And this concludes our presentation. Thanks, Dr. Bull.